Okay. Bismillahirrahmanirrahim. Assalamu alaikum. Thanks for joining us on our third day of Shaukat Khanum Symposium. So it's our first session on hematologic malignancies. We've got four excellent talks. Three of them are virtual and one is physical, and we've got panelists at the end to have a Q&A session as well. So in our chairs, we have got Dr. Bushra Hassan. She's lead for lymphoma services at Shaukat Khanum Hospital and consultant clinical hematologist. We've got Dr. Syed Waqasim Bukhari, who is lead for DMT services, and he's a consultant clinical hematologist at Shaukat Khanum Hospital as well. Our first speaker is Dr. Tanya Siddiqui. She's a director of chronic lymphocytic leukemia program in City of Hope Hospital, National Medical Center, USA. So over to Dr. Tanya Siddiqui.
Assalamu alaikum. My name is Tanya Siddiqui. I'm from City of Hope Medical Center in California, Southern California. And I'm here to talk to you about some latest updates in the management of chronic lymphocytic leukemia in the frontline setting and at the time of first relapse. These are my disclosures. Here's the agenda of what I will cover today. Of course, you know, it's pretty bare bones here, but mostly I'll be talking about targeted therapies because that is what we now use in CLL almost exclusively in the US, very, very little chemotherapy anymore. So let's talk about the frontline treatment options in CLL. Clearly, there has been a huge paradigm shift in the treatment of CLL with the advent of targeted therapies, you know, targeting things like kinase inhibitors, CD20, and several other things. We will talk about a few of these, but I just wanted to show you a diagram of what all is involved. And this is a very simple diagram, of course. But we are now able to target, you know, many different submolecular or molecular level proteins and enzymes in the pathway of an overactive B cell that has led to CLL production. And each of these targets, you know, has its own unique side effects when you inhibit it, but it's certainly nothing like chemotherapy that affecting the whole body, for instance. So here's a current paradigm of how we treat patients in the frontline setting if they're not on a clinical trial. Our first goal always is to try to put them on a clinical trial, but if they're not, some patients prefer fixed duration therapy. So we try to start with venetoclax plus obinutuzumab, which is a 1-year fixed duration treatment. Alternatively, you could start with a BTK inhibitor like acalabrutinib plus minus obinutuzumab. And I've been able to stop acala in this setting in, you know, a 1.5 years or 2 years, depending on how deep a remission patients are in and how annoying their side effects are that they would like to take a break from them. It's a discussion with the patient, of course. I think in the first relapse setting, the general rule is that if you started with venetoclax, well, now you can turn to a BTK inhibitor and vice versa. But as I said before, our goal always is to put people on clinical trials to try novel therapeutics, newer combinations of targeted therapies, et cetera. So what happened to chemotherapy in general? You know, CLL used to start with chemotherapy in the past. There were many, many trials now, phase 3 trials that have shown in a randomized setting that the novel agents are better than chemoimmunotherapy in the frontline setting, for instance. And E1912 trial, Alliance, Resonate 2, they all treated patients of different types, like younger fit. In the E1912, the Alliance had like a little bit older, less fit, and Resonate 2 had patients who were even less fit and probably older. And that was the first trial that came out that showed that ibrutinib was better than chlorambucil, for instance. But now with the E1912 trial, we know that ibrutinib plus rituximab is better than FCR. And with the Alliance trial, we know that ibrutinib or ibrutinib plus rituximab is better than bendamustine and rituximab. So I think the data is there, and clearly we are impressed by that data. Here's the one example of such trials. So E1912 trial. It took patients who were previously untreated, younger than 70 years of age or equal to 70 years of age, generally fit with good kidney function, ECOG performance status 0 to 2. No 17p deletion by FISH because clearly we know that patients who have those do not do well with chemotherapy. So we would not have subjected those patients to the randomization on this trial. You can see that ibrutinib plus rituximab is shown on top, which is arm A. Rituximab goes on for a total of 6 cycles, but ibrutinib starts before that and goes on sort of indefinitely until disease progression or intolerable toxicity. Arm B is FCR for 6 cycles, and patients were followed over a long period of time. There's a recent update on this trial, which showed the reasons for ibrutinib discontinuation over time, and you can see that 138 patients discontinued and those are the reasons in the last column, and the reasons are given below as to why. Most of those reasons were adverse events or complications, and some were progressions as well. And here are the progression-free survival curves. So you can see that the red curve, ibrutinib plus rituximab curves, do better with the whole progression-free survival of all the patients compared to FCR. And then in B and C, you can see that patients with IGHV unmutated did a lot better with IR. And even the patients with IGHV mutated status, after a while, the curves seem to separate, and there is a statistically significant improvement in PFS with IR, even in that group of patients, although initially we thought in the early part of the curves, we thought that they were similar. So maybe chemo could have been used in IGHV mutated patients, but not anymore. We know that after a while, the patients with IR do seem to do better than the patients who got FCR over time. And then in D, you can see that these are patients who have continued IR over many years and seem to be doing quite well. The cutoff, the runoff on that curve is not very steep or quick, so they do very well for many, many years. And a quick look at the overall survival curves at the 6-year follow-up. Even this is statistically significantly better for ibrutinib plus rituximab compared to FCR. It's hard to argue when you see an overall survival advantage, of course. So bottom line, with E1912, we know that ibrutinib and rituximab did better with PFS and OS compared to FCR. In younger patients with previously untreated CLL, the median follow-up was 5.8 years, and about 60% patients continued on ibrutinib at that time point. It seems about 10% patients did progress while on therapy, and among all the patients who discontinued ibrutinib prior to disease progression or death, I didn't show this data, but they did not progress for at least a couple of years after finishing their last dose of ibrutinib, which is a relief that they weren't progressing right away when they stopped ibrutinib. And I won't go into details of these 2 trials, but I did mention earlier that RESONATE-2 is now one of the oldest trials comparing ibrutinib with chemo. Of overall survival than the chlorambucil curve. And on the right, you can see the Alliance trial at a 3-year follow-up, where ibrutinib plus rituximab or ibrutinib patients did much better than the bendamustine and rituximab patients in terms of progression-free survival. A very clear benefit of ibrutinib was seen across all risk subgroups. Venetoclax is the next product to kind of show its benefit in CLL frontline setting. So this is the CLL-14 trial done by the German CLL study group, essentially in combination with a lot of centers all around the world. Basically, they took patients who were previously untreated, who had CLL, but also had some coexisting medical condition where they wouldn't not necessarily have been eligible for FCR historically, so they could have been eligible for chlorambucil plus obinutuzumab as a standard arm technically, and there was a one-to-one randomization between ven-obin and chlorambucil-obin for 6 cycles, and then the tablets, the oral treatment on each arm continued for another 6 cycles, and everybody stopped treatment at the end of 1 year. The progression-free survival was the primary endpoint of this trial. And to cut a long story short, you can see that the ven-obin patients did a lot better at over a 3-year follow-up in progression-free survival compared to chlorambucil plus obinutuzumab. These patients also had improved undetectable minimal residual disease to a level of less than 10 to the -4 by flow cytometry. And these patients who were undetectable by UMRD were also more likely to be in a complete remission with venetoclax plus obinutuzumab compared to chlorambucil plus obinutuzumab, and this was true in the peripheral blood and in the bone marrow. Progression-free survival curves are shown here by MRD status, and so you can see that the darker black lines show venetoclax plus obinutuzumab, with the top dotted line being UMRD positive, meaning UMRD, undetectable minimal residual disease, and the solid black line further down is MRD positive patients who are on the venetoclax arm. So you know that you can see that progression-free survival will be better if patients achieve UMRD compared to not, essentially. And similarly for chlorambucil, even though UMRD was lower overall, but the patients who did achieve UMRD with chlorambucil also did better than those who didn't, technically. So the authors concluded that fixed duration venetoclax and obinutuzumab continued to show a superior outcome compared to chlorambucil plus obinutuzumab across all risk subgroups, essentially. They don't see an improvement or change or difference in overall survival yet, but they do see very high rates of undetectable minimal residual disease at the end of that 1-year treatment, and this has seemed to translate into sustained progression-free survival benefits. More than 90% of patients are showing durable responses 2 years after end of treatment, and that is excellent. That means they don't need treatment right away. This also seems to confirm that there is a prognostic value of minimal residual disease, at least in the. We conclude that with the CLL-14 trial, we found high rates of MRD undetectable remissions. This is a very attractive frontline regimen for a limited time period of treatment. And patients who don't achieve undetectable MRD still have a median progression-free survival of 2 years. And there are many questions as to whether or not they should stop therapy if they haven't achieved UMRD, but we aren't really using MRD as a decision making result. So we're not quite sure whether we should use that to continue treatment in these patients or whether they should change therapy and use something else for maintenance. Those trials are starting and are kind of ongoing. We don't have all that data yet. The third topic in frontline setting I'd like to talk about is acalabrutinib trial. So this is the Elevate-TN, or treatment-naive trial, which involved several hundred patients of 65 years or older, or if they were younger than 65, then with some coexisting condition, which made them a little bit frailer. And you can see that patients were randomized 1:1:1 between acalabrutinib plus obinutuzumab versus acala versus obinutuzumab plus chlorambucil, and the primary endpoint was progression-free survival of the acala-obin versus the chlorambucil-obin arm specifically, like the combination arm specifically, not really the single-agent acala arm. The independent review committee assessed this progression-free survival here at a median follow-up of 28.3 months, and you can see that both the Acala arms did significantly better than the chlorambucil plus obinutuzumab arm, and this was statistically significant. In addition, the response rates were significantly better for Acala plus obinutuzumab, as well as Acala alone compared to chlorambucil plus obinutuzumab overall. I think with BTK inhibitors, we are interested in the AEs of interest, which are atrial fibrillation, hypertension, bleeding events primarily. These are some of the class effects of BTK inhibitors. So you can see that there were some events of atrial fibrillation, but really very, very few compared to what we used to see with ibrutinib, for instance. So 3% and less than 1% for grade 3 or higher AFib, about 7% hypertension, but less than 3% for grade 3 or higher hypertension with the combination of Acala plus obinutuzumab, maybe a little bit less in both cases of using Acala alone. And then bleeding certainly does happen, but most of it by and large is lower grade. Really very few grade 3 or higher events, less than 2%. And infections were also seen, but they were also seen in the chlorambucil arm. And this is just, unfortunately, anytime you treat lymphoma, you get rid of some of the healthy B lymphocytes, and so you put people at a little bit higher risk of infections. Although with some BTK inhibitors, we have seen a little bit of aspergillus or crypto or some kind of opportunistic, more life-threatening infections, and then I don't use BTK inhibitor again in those patients. If they do have some of those weird opportunistic type infections. We're not too worried about any rise in secondary primary malignancies because we know that CLL as a disease can be associated with higher secondary cancers. So that's just something we're keeping an eye on over time, but certainly we're not too concerned that acalabrutinib itself is causing any secondary cancer. The author's conclusions on the Elevate-TN trial is shown here. So both the Acala arms had significant improvement in progression-free survival compared to the chlorambucil arm. There was a tolerable safety profile as well. The benefit of adding obinutuzumab, isn't really clear, but they did very well, clearly. And we think that Acala demonstrated efficacy as well as a consistent safety profile in these patients in the frontline setting. And we've seen some of these results similarly in the relapse refractory setting as well. And now, of course, this is an coming to the first relapse. Here are some of the treatment options. Of course, I haven't exhausted all the list, but here are some of the representative studies. So if somebody started with a BTK inhibitor, then at first relapse, I tend to use venetoclax preferentially, and the Murano trial data is a good support of that. So patients who had relapsed CLL were randomized in a 1-to-1 fashion between venetoclax plus rituximab, fixed duration therapy versus bendamustine and rituximab. BR was 6 cycles as always, but Ben-R was 6 cycles of rituximab plus, but the venetoclax goes on for a total of 2 years, and then everybody stops. And the primary endpoint was progression-free survival. There are the progression-free survival curves, and you can see that venetoclax plus rituximab patients, which is the top purple line, did a lot better than the BR patients over a 2-year post end of treatment follow-up. That means that after everybody stopped at 2 years, even much later than that, patients had a sustained progression-free survival benefit. And moreover, an overall survival benefit was also seen with this combination of bendamustine and rituximab. So here's more proof that chemoimmunotherapy really does not work even in the relapsed refractory setting in our patients anymore. And we should try to stick with targeted therapies as much as possible to provide them with the best chance of prolonged remissions. Authors concluded that after a median of 48 months follow-up, progression-free survival and overall survival benefits were sustained with fixed duration venetoclax plus rituximab compared to BR. After treatment finished, progression-free survival was sustained at 22-month follow-up with a 24-month PFS estimate of 68%. And UMRD again was shown to be associated with a more prolonged progression-free survival. The patients who were MRD positive, but at a higher level of MRD positive, really had increasing MRD levels prior to end of treatment. And it wasn't clear whether continuing venetoclax treatment in these patients would benefit them. It seems to mean that they were already progressing on venetoclax, but the overall survival curves really indicate the value of putting venetoclax in the mix early, maybe at first relapse in these patients rather than waiting after they've had more chemo and things like that. So I think, again, you cannot argue with an overall survival advantage. I think we've clearly learned that. And there were no new safety concerns of venetoclax plus rituximab. We all know how to use venetoclax now. It has to be done at a slow ramp up over 5 weeks in CLL patients to prevent major tumor lysis syndrome. And I like to check the tumor lysis labs, within 24 hours after taking the first dose of the ramp up every week. So typically I do it for at least 3 weeks, if not the full 5 weeks. But early on, it's important to keep an eye on those stat labs right away after starting a new dose level. There is some data to show that in a retrospective fashion, that if you look at real world experiences with venetoclax, if you did venetoclax followed by BTK inhibitor, venetoclax followed by PI3K inhibitor, or venetoclax followed by cellular therapies at the time of next relapse, let's say, then there are some differences in patient responses. And so this accumulation in a retrospective fashion of some of this data across many different sites in the world, actually, did try to take a look at this and present it in a fashion that maybe made some sense, but of course we need to look at it in a more prospective fashion ultimately. So the authors showed this table looking at response to subsequent therapy after a patient has stopped venetoclax for some reason, primarily for taking a break or maybe progression. But you can see in the second column, for instance, if the patient got BTK inhibitor next after venetoclax and they had never had BTK inhibitor before, they had a chance of 84% overall survival with this next line therapy. But if they got BTK inhibitor next, but had already been exposed to BTK inhibitor before, and especially if they were resistant to BTK inhibitor before, then the BTK inhibitor tended not to work as well 53% of the time, et cetera, et cetera. You can see how the curve, how the graph, how the table moves on and is read that way. But clearly for patients who had never had BTK inhibitor before, but had started with venetoclax and now get BTK inhibitor, that seems to work 84% of the time, and really just prove that you can use it as second line potentially. And so my overall conclusions for this talk are shown here. So in the frontline setting, you can use a BTK inhibitor plus minus obinutuzumab. It provides excellent responses, but may need more ongoing BTK inhibitor therapy in an indefinite fashion. Whereas if you start with venetoclax plus obinutuzumab, provided patients have good renal functions, etc., you can get away with fixed duration therapy for 1 year, and then patients may not need treatment again for several years afterwards, which some patients prefer, especially the younger ones. At the time of first relapse, if patients had never had venetoclax before, then the Murano data shows that 2-year treatment with venetoclax plus rituximab gives very good disease control for several years. Whereas if patients had had venetoclax in the first line setting, then a BTK naive patient would have excellent results with BTK inhibitor therapy as a second line agent. And so I think we have a very good plan already in place for commercially available drugs, at least in the US. But we are now trying to find more novel combinations, newer treatments, newer targets in either frontline or relapse refractory settings to kind of see if we can, hopefully cure patients ultimately, but at least try to get them in such a deep remission with fixed duration therapy that you don't need to continue incurring indefinite costs, and patients don't need treatment right away for several years after some kind of fixed duration therapy. For instance, ibrutinib plus venetoclax plus minus obinutuzumab is being tried, etc. There are many new combinations that are being tried in the US at least. So I don't know how much of this will translate to Pakistan. I hope some of it does, because I think in the interest of treating patients with the latest and greatest and best treatments that can affect not just progression-free survival, but also overall survival, I think it's very important. But I do understand that costs can be prohibitive as well. And hopefully pharmaceutical companies can come up with some very for countries like Pakistan and also countries like the US, where the poor retired community patients have, a lot of cost issues. Thank you for your attention. And with that, I'm happy to take any questions if there are any. Thank you.
Thank you, Dr. Tanya. We'll take questions right at the end. So we'd like to move on to the next talk. So our next speaker is Dr. Natasha Ali. She is an associate professor in hematology and associate dean in the Department of Professional Education at Aga Khan University Hospital. She is going to talk about acute myeloid leukemia, alternatives to DA chemotherapy. Over to you, Dr. Natasha.
Assalamu alaikum and a very good morning to all of you. Thank you so much to the organizers for giving me the opportunity to talk on a very important topic. It's bread and butter of a hematologist treating acute myeloid leukemia. But what we're going to talk about today is alternatives other than the 3+7 chemotherapy that we use to treat these patients. So I have nothing to disclose. This is going to be the outline of the talk. It's always nice to start off with the basics. So we're going to discuss how a normal functioning hematopoietic stem cell turns into a leukemic stem cell. There are various targets present in that AML blast that are now present and have been discovered, and we're going to talk about that. And based on those targets, what are the newer therapeutic agents available with their efficacy and their feasibility? A very upcoming potential resource or source of research these days is the bone marrow niche that researchers are working on, and going to spend a couple of slides on that, and in the end I'll summarize. So from starting with the basics, we all know that this is your hematopoietic stem cell. And it is recognized by the fact that it has the ability of self-renewal. And this HCS gives rise to multipotent progenitor cell, which then gives rise to two of your common myeloid progenitor cell and common lymphoid progenitor cell. The CMP gives rise to your GMP, which is granulocytes, monocytes, and megakaryocytes and erythroid progenitors, which then form your peripheral circulation cells, which are your granulocytes, macrophages, erythrocytes, and platelets. On the other hand, the CLP gives rise to the BT and natural killer cells. And when you take all of this hematopoietic stem cell tree into consideration, think of how a leukemia stem cell develops. So it can develop, or your cell of leukemia can originate from either the HCS, when there is a mutation, and this mutation can cause a lot of things, a block in differentiation, a block in self-renewal, and then 2 or 3 hits in this HCS eventually can lead to a leukemic stem cell. On the other hand, the second part where the cell of leukemia can arise is your multipotent progenitor cell. And this can take a hit too, just like the one over here, and then eventually they're going to give rise to a leukemic stem cell. The basic ability of this cell is there is a complete block in self-renewal, differentiation, and the only way it can progress forward is the formation of blasts giving rise to leukemia. So that is how leukemia originates inside the bone marrow. So AML is a very, very heterogeneous disease. There are numerous potentially druggable signaling pathways that are present inside this leukemic AML blast. And all of these pathways now have druggable options available with numerous trials and studies, and we'll take that one by one. So when we talk about FLT3, the famous FMS tyrosine-like kinase receptor, which is a transmembrane receptor kinase present outside of the membrane, and when the ligand attaches to this part of the tyrosine kinase domain, it instigates a JAK-STAT signaling pathway downstream, which is responsible for your cellular differentiation, proliferation, and cellular survival. So this is one of the pathways through which your cell proliferates and gives rise to other progenitors. So FLT3 inhibitors were discovered a decade ago. And there are a few studies that I'm going to discuss. The first one is a systematic review where 8 complete studies were included. This had all the RCDs. And this is the forest plot of all the available FLT3 inhibitors present in the market. Well, it clearly shows that there is an unfavorable advantage when you use FLT3 inhibitors with intensive chemotherapy. And then when they've used, when these FLT3 inhibitors have been used with the DA chemotherapy, the overall survival has been from approximately 60 to 80%. And this is in younger fit patients who have undergone intensive chemotherapy followed by transplant. When you come to the older population who are unfit for intensive chemotherapy and you use it with low dose chemotherapy, and that low dose can be azacitidine, decitabine, or you use it alone, the survival has not been that great as compared to the previous slide. So it's been 6 months, maximum of 8 months. And the other part of using a FLT3 inhibitor with low dose chemotherapy is that once you achieve a response, you can wait and watch, but eventually, if they have poor risk cytogenetics, these patients are going to eventually relapse. And then, most of the trials then say that once you achieve a remission, you need to continue these drugs till you see that the clinical benefit is still happening. Becomes a lot to bear as far as the cost is concerned. And then with a survival of 6 to 8 months, I would say it is not worth it at the moment. This study was published 2 weeks ago. It is that latest. And this study has compared a newest FLT3 inhibitor, gilteritinib. It was approved 2 years ago in 2020, almost 2 to 3 years ago. And this study has compared a combination therapy of gilteritinib with azacitidine alone. So the complete remission responses have been better as compared to using azacitidine alone. But as far as the overall survival, it is not shown a very, very high significant clinical overall survival benefit. So for patients who don't have an option to undergo transplant, who don't have an option where you can use intensive chemotherapy, this is a combination to use to achieve a durable complete response. But if you don't use gilteritinib and use azacitidine alone, the overall responses have seemed to be the same. There's been no difference. So what are the practice points? All younger fit patients with a FLT3 mutation, give them intensive chemotherapy. Gilteritinib is not available in Pakistan. Sorafenib is, midostaurin is not available in Pakistan, but this is the combination. You use a FLT3 inhibitor with intensive chemotherapy, consolidate it, give them high dose cytarabine, and you take them up for transplant. And once they do receive a transplant, you continue the FLT3 inhibitors for at least 2 years to maintain that consolidation that you've achieved after transplant. Sorafenib. So this is what's available in Pakistan, and a cost of 1 month treatment is this. This may come down a bit if you reduce the dose from 400 to 200 if they're not able to tolerate a 400 milligrams dose. But this is the roundabout cost that the patients have to pay out of pocket if you want to continue them on a FLT3 inhibitor. Hedgehog pathway. This is a very interesting pathway. So hedgehog, actually, this is a pathway that is active in the embryonic life, and this pathway is responsible for cellular differentiation in utero, and it is completely silenced in adults. In a normal, healthy, functioning adult, this pathway is completely silent. It is not responsible for cellular proliferation. In the AML leukemic blast cells, there is an aberrant upregulation of this pathway. And this leads to then leukemogenesis and uninhibited, unchecked blast proliferation. The drug which directly goes and hits this pathway and has been approved recently in 2018 is Clastigib. This was a trial where the patient population was two, and they compared patients with good and intermediate risk cytogenetics with those with poor risk cytogenetics. So for the poor risk cytogenetics, there has been absolutely no difference in the median survival when you use it with a low dose Ara-C. But as far as the good and intermediate risk cytogenetics is concerned, the arm where this inhibitor was used did better than the arm that only received low dose Ara-C. This has been used in a very limited subset of patients. So age more than 75 years, comorbidities, cannot undergo intensive chemotherapy. This is something that you can offer. Glasticib is an oral drug. It's a potent inhibitor of the pathway, and if it gives you good responses in combination with low dose Ara-C, and if it's available, one of the options is that you can offer them to a very limited, more than 75 years subset of patients. One cycle, price of one cycle is $17,000. So since it's not available in Pakistan, this is the international drug price. And the recommended dose is 100 milligram. Like I said, it's oral, 100 milligrams once daily. CD33. So when we're diagnosing AML in the lab, this is the marker that we usually look for positivity in diagnosing AML on flow cytometry. So this is a surface antigen that is very highly expressed on the myeloblast. And as the cell matures, this is completely gone because it is exclusively present in the myeloblasts. So when you have a patient with AML, CD33 is very widely expressed on the cell. And that gives a plethora of binding sites of anti-CD33 to go and bind, conjugate, and give the cytotoxic T cell killing response. Gemtuzumab has been a very notorious drug. It was first introduced in early 2000, and it was approved by FDA very rapidly when it was introduced. There were phase 3 trials going on, and the researchers had said that the responses have been very durable, and the endpoint can be seen once the trials continue, and therefore FDA gave its approval. And once that happened, there were a lot of adverse reactions leading to deaths, fatal adverse reactions leading to hemorrhage, and therefore the drug was withdrawn from the market in 3 years after being approved. And therefore, after that, in about 10 years, it was resurrected and reintroduced, and we'll take a look how. So this is an anti-CD33 monoclonal antibody. It conjugated to a DNA binding cytotoxic antibiotic. Initially, it was approved in US and Japan, and this was approved for patients with relapsed AML, refractory and relapsed AML, not approved to be used upfront. And because of deaths and other side effects, it was withdrawn from the market. In 2010, the trials that conducted decided that let's have a look at the potentially toxic doses that had reached to the deaths. Let's have a look at lowering down the dose and combining it with intensive chemotherapy, and let's see how that goes. So in 2010, it received a second approval, and this time it was used for treatment in patients with newly diagnosed. So remember, when it was withdrawn, it was for patients who were not eligible for chemotherapy, they had relapsed, they had refractory disease, but when it was reintroduced, it was introduced for patients with newly diagnosed AML. And this is a trial where 280 randomly assigned patients were taken. This was done across 26 centers, and they were equally distributed in the control group and the ones that received gemtuzumab. And then they had undergone the induction chemotherapy, achieved remission, and then they went on to receive at least 2 cycles of consolidation with gemtuzumab. And the graphs seem to separate clearly, and there was very, very good survival benefit in adding GO to the intensive chemotherapy regime. And what they did was they gave low dose burst of gemtuzumab, and this allowed them to give higher cumulative dose eventually of the gemtuzumab instead of giving a very higher dose and leading to cytotoxicity and deaths. So the dose now approved to be used of gemtuzumab in intensive chemotherapy is 3 milligram per meter square for combination therapy, and you can also use it as a monotherapy, and the dose for that is 6 milligram per meter square. IDH1 and 2, isocitric dehydrogenase. So if you remember your Krebs cycle, isocitrate dehydrogenase is the enzyme that catalyzes the deoxidation of citrate to alpha ketoglutarate. This is way back in medical college. Neomorphic mutations in the catalytic site of this enzyme gives rise to a mutant enzyme. And that mutant enzyme then gives rise to a mutant oncometabolite, which is R2 hydroxyketoglutarate, and that causes aberrant activation of the blast cycle and leads to uninhibited proliferation. So the drug approved for this are 2 because there are 2 isoforms of the same enzyme, IDH1 and IDH2. Therefore, there are 2 drugs, one acting on IDH1 and one acting on IDH2. So the first drug is ivosidenib, and this has been used in combination with azacitidine. Again, that's limited subset of population, more than 75 years, comorbidities, cannot undergo transplant, cannot receive intensive chemotherapy. This is the group where these drugs were tried. And clearly the event-free survival and the median follow-up of the combination treatment proved to be a better option in these patients. This drug is oral in combination with azacitidine, which is a subcutaneous injection, very good compliance. So this is a daycare-based therapy. Your patients can come in, get the injection, go home, and take the drug orally. So if available and if your patients can afford, this is again a good option. If this pathway is active, then this is a good option to be tried in that subset of patients who are more than 70 or 75 years old. The second drug is inasinidib. This was a phase 2 trial done in 2017. 239 adults were included. They wanted to expand the dose here, but that wasn't possible. So finally, a dose of 100 milligram was chosen to take forward in the trial. The overall response was 40%, not bad for AML in more than 75 years. The CR was about 20%, and the median overall survival is again 20 months. 30,000 for a 30-day cycle. So again, cost becomes an issue, and of course, availability as far as Pakistan is concerned becomes an issue. The newest kid on the block, and the previous speaker just spoke about venetoclax, now in AML is venetoclax, and this has been used in combination with azacitidine. So initially it was not approved for AML, it was approved for CLL, exclusively for 17p deletion. And then that approval was extended in 2018 to patients with at least, they've received 1 prior therapy. And finally, again in 2018, it was approved for acute myeloid leukemia in combination with hypomethylating agents, be it azacitidine or decitabine, again in 75 years or older. So this is the data for AML and venetoclax. And if you look lower down the chart, then your overall response rate has been pretty good, 76%, 54, 71%. And the median overall survival is ranging from 10 months to at least 17 months. For patients where intensive chemotherapy is not an option, this is actually a very good option. It is available in Pakistan. We've been using it very regularly. And I'll show you some data of our experience as well. So this is a very, very recent trial that has been published. So if you look at this chart, then using azacitidine alone as or with a placebo, as compared to azacitidine plus venetoclax, clearly provides a very good survival advantage when you use it in combination therapy. So for our data, I've just used a subset of patients for the last 2 years. The median age was 55 years, ranging from 25 to 75 years. And this is an outlier, and I can tell you why we use this. There were about 16 males and 7 females in our data. So this is for, so we used this combination patients with myelodysplastic syndrome, which was 10, and AML both. So this is MDS plus AML data, and that 25 years a patient was a patient of MDS, not AML. So we've used azacitidine alone in 5 patients, whereas mostly we've used as a combination. The commonest cytogenetic abnormality in this subset was monosomy 7, and monosomy 7 seems to stand out in our population. If you pick up studies, local data of cytogenetics in AML and MDS, monosomy 7 is very common in our population, and in this subset it was 22%. In few patients, we were able to give a minimum of 1 cycle because of toxicity and deaths, whereas in 34 patients, we gave a maximum of 6 cycles in this subset. The median survival was 17 months, ranging from a year till 2 years. In 16 patients, this treatment was given upfront. And in 7 patients, this was second line. One of the patients in this subset underwent a transplant after giving a triplet therapy of azacitidine, venetoclax, and gilteritinib. Right now, he is in remission with few grade 1 GVHD, otherwise he's doing well. So that is one combination that we've used in our setup as well. So what are the caveats of all of these drugs? These are very good genomically defined therapies, and you saw from the data, the response is there, it is available, they do achieve it, but the duration is very short-lived. And that's the biggest caveat of these drugs. We have the ability to target one mutation because it's druggable. But because of the short duration of response, it does not translate into a very significant disease impact. These drugs are an excellent source to be used as a bridge to transplant. So in young patients, give them the druggable targeted therapy, get them into remission, and take them up for transplant. So like we do for FLT3 inhibitors, give them in consolidation cycles, achieve a good remission, and take them up for transplant. So these are very good targets to do a bridging sort of for the allogeneic stem cell transplant, which eventually actually is the consolidation treatment for FLT3 or other inhibitors or other druggable or signaling pathways positive patients. The future maybe is to combine, we've combined 2 therapies, maybe combining 3 or 4 therapies together to achieve that duration of longer response or CR in these patients is the way to go. Last, bone marrow niche. So this is how your chemotherapy works. There are AML cells in the circulation, you give them chemotherapy, they undergo apoptosis, but few of these AML cells are very smart. They build up receptors, which are receptors that are responsible or homing of stem cells into the bone marrow niche. And once they do that, they act like stem cells and they go and hide in this area, which is the pericenocidal compartment of your stem cell niches. And eventually, these are the cells which has homed in this area, eventually come into the circulation and cause a relapse. So now the targets or the druggable targets is not the peripheral circulation, is not the bone marrow, but it is this compartment which is responsible for relapses in patients with acute myeloid leukemia, which is the new area focused for research, how to combat this. So in summary, we had Daunorubicin and cytarabine for the last 40 years when it was discovered, and we've been treating patients with AML with that. But in the last 4 or 5 years, 8 or 9 new drugs have come into the market, and all of them have achieved FDA approval for treatment. Um, it would not be, but hard to say that the results of these targeted therapies have been very encouraging as far as the complete responses are concerned. Most of them have been used in the relapse refractory setting, and it makes a good choice after your patient has relapsed after DA therapy. A maintenance therapy, and you remember and you would know that in AML there is no maintenance, it is in ALL, but for exclusively FLT3 positive AML, maintenance therapy is making a resurgence. And a lot of trials have said that if you don't do a transplant, you continue FLT3 inhibitors with FLT3 positive patients for life, as long as you see the clinical benefit. The way forward is to combine doublet and triplet therapy in a good, rationally designed, randomized controlled trials. And last but not the least, it's a bone marrow niche that we need to target to control acute myeloid leukemia. Thank you.
Thank you, Dr. Natasha, for an excellent talk. So just take a seat. We'll come back to you in the Q&A session. So our next speaker is from the US, Dr. Saad Usmani. He's well known for his work in myeloma. He's currently the director of Plasma Cell Disorder Program and clinical research in hematological malignancies at Memorial Sloan Kettering Hospital. So he's presenting virtually. So his talk today is evolving management of upfront treatment of myeloma.
Hello and assalamu alaikum. My name is Saad Usmani. I'm the chief of the myeloma service at Memorial Sloan Kettering Cancer Center, and I will be talking to you about managing newly diagnosed multiple myeloma in the year 2022. All the lessons we've learned, with the advances in disease biology understanding as well as these. These are my disclosures. I want to make an important statement about multiple myeloma. It's not one disease. It's at least 7 or 8 different molecular subtypes that behave differently from a survival outcomes and biologic perspective. We see patients from this pre-malignant MGUS condition to an active myeloma in different transition period times. So patients will present to us with varying degrees of end organ damage as well as disease burden. What's important to appreciate is we have been able to establish management strategies that improve the survival outcomes for myeloma, specifically for standard risk disease patients. It's going beyond 10 or 12 years now. But a lot of work is still left undone. I think, we are now focusing more on understanding the role of the bone marrow microenvironment and how best to regulate and modulate the immune system in myeloma patients. And at the heart of this is, the notion that we have to pick the right strategy for any given patient, regardless of, the molecular subtype of their disease, and give them the best likelihood of depth of response in that first year of diagnosis. The deeper the response, the better the survival outcomes. And that's the theme that we've seen in standard risk disease as well as disease. In the United States, this year we will likely have closer to 36,000 new cases. But I still recall the time in the early to mid 2000s when I was just starting my training here. In the US, we used to have about 15 or 16,000 newly diagnosed cases at that time. But the number of people dying from the disease was about the same. It was around 11 or 12,000. So what we've done, with the newer therapies is really, improve the survival outcomes where, less number of patients are dying, but the disease still remains, incurable by the conventional definition. And, that's where we're trying to head towards is curability of the disease. The median age of diagnosis is 69, but African American or Black American patients tend to present at a younger age. Men tend to present at a younger age as well. And this is something that we have to be cognizant of here in the US specifically. If we look at the history of multiple myeloma therapy, we have come a long way from back in the late 40s and early 50s when some of the conventional chemotherapies were being earmarked for different cancers. And for multiple myeloma, melphalan in low doses along with corticosteroids was being considered as the standard of care. In fact, it was Dr. Raymond Alexanian's paper in the early 60s that established that as a standard of care. And for almost 20 years, that remained the case until the early 1980s saw people like my mentor, Dr. Bart Barloghi, looking at high-dose melphalan with stem cell rescue as a mechanism of controlling myeloma disease with a good effect in the relapsed setting. And that led to several clinical trials establishing high-dose melphalan as a standard of care for younger myeloma patients. In the late 90s, it was the emergence of immunomodulatory drug, again with Dr. Barloghi, observing thalidomide's clinical activity in relapsed myeloma that heralded the novel therapy era, along with Dr. Ken Anderson's work with proteasome inhibition, along with Dr. Robert Orlowski around that time in the early 2000s. And really from the 2010s onwards, it was the second generation small molecules and importantly immunotherapies that started to be examined in clinical trials. And that led to this improvement in survival outcomes from 2010 and onwards. And this whole landscape is continually changing. But some of the things haven't kept with the times, and we're trying to improve upon them. For example, staging and cytogenetic risk assessment, we recognize as an important part of myeloma prognostication. And now we're even developing therapies based off of standard versus high-risk features, but we do not have a good mechanism of capturing the prognosis at the time of diagnosis. Even here in the United States, we're unable to do a very good job. So I can imagine, having been to Pakistan on several occasions and having had conversations with the oncology community there, many of our patients being diagnosed do not have these prognostic assessments done at the time of diagnosis. So this all, is something that can be changed, especially in emerging economies, and the technology is becoming cheaper and cheaper. The paradigm for newly diagnosed myeloma patients, has been about assessing transplant eligibility, and really, transplant eligibility or ineligibility is in the eye of the beholder. It's not age dependent. It is primarily comorbidity and performance status dependent. Patients based on this assessment go on to receive initial therapy, typically with a 3-drug combination, where I'll talk a little bit more about quadruplet induction regimens that we're utilizing. Then post-transplantation or post-initial therapy in transplant-ineligible patients, once the response is plateaued, patients move on to maintenance treatment. We also pay attention to infection risk, bone health, pain management in the supportive care category of things. And if and when the myeloma does come back, we do restaging and kind of reassess the treatment options for our patients at that given point in time. So how did we arrive at the initial 3-drug induction treatment? It was primarily based on the SWAP 777 study, where RVD was compared to RD as part of induction. One critique of this particular study is both transplant eligible and ineligible patients were included, and patients actually had a deferred transplant kind of strategy. Here, the bottom line is that the 3-drug combination won the day in terms of PFS as well as overall survival. But I can tell you that many of us, even at that time when the study read out back in 2016 and 17, had already moved on to 3-drug inductions for majority of our patients. The IFM 2009 study, again, has this question of early versus delayed transplantation with high-dose melphalan and autologous stem cell rescue, where all patients had received IVD as part of induction, collected cells, and then were randomized to either an auto followed by 2 cycles of RVD consolidation or just 5 cycles of RVD. And there was a second randomization to LEN maintenance for up to a year. This study read out positively in favor of autologous stem cell transplantation, again, going with the theme that patients who got a transplant had a much deeper response during that first year of diagnosis, with MRD negativity or minimal residual negativity rates being, quite high. And MRD negativity is the next, new complete response or CR. It's the new CR in myeloma, and it's a flow or a next generation sequencing based assay that is done. And in Pakistan, a flow based assay can easily be done for patients instead of the NGS panel. However, the message here was transplant still has an important role in the front setting, and in fact, the determination trial that was just presented earlier this year at ASCO and published in the New England Journal of Medicine by my colleague, Dr. Paul Richardson, was a sister study to the IFM 2009, but took a while to read out in the United States because LEN maintenance was continued until relapse and progression. So this particular trial, again, read out positively in favor of early transplantation. The median follow-up was 70 months, and the primary endpoint of PFS was met. The secondary endpoint of time to progression was met. The OS showed, not being reached in either of the arms of the study at the 17-month mark. So we need to continue to follow this carefully. One interpretation that people try to make, which was kind of incorrect statistically, is saying that there is quote unquote no OS difference in the determination trial. That is factually inaccurate because the median has not been reached. And if the median OS for this patient population is about 10 years or so, you won't see a difference until at least both arms reach that 10-year follow-up. You won't start seeing that separation of the curves. So that's important to appreciate. Second, primary malignancies were similar across the 2 arms, but there was a higher incidence of AML-MDS in the transplant arm, and there was a signal for ALL actually being, a bit more common in the RVD alone arm of the study. Another very important trial in this space is the Griffin trial. So this is where the antibody, monoclonal antibody targeting CD38 daratumumab was added to RVD as part of induction post-transplant consolidation, and then added to maintenance as well. So this is a study that was led at my previous center by one of my team members, Dr. P. Voorhees. And this study was a randomized phase 2 that actually informed 2 randomized phase 3 studies that are about to read out here, they will likely lead to a higher number of patients with sustained MRD negativity beyond the 1-year mark, in the data arm of the study compared to the RVD arm of the study, making the case that the depth of response and sustainability matters when you're utilizing the most effective therapies in the frontline setting. However, we don't have a good sense of what the impact of data is in the high-risk patients. In the high-risk transplant eligible patients, what gets patients better survival outcomes in terms of median PFS is inclusion of a proteasome inhibitor into the maintenance strategy. And this is something that was observed when the endurance and the SWOG 1211 studies were reported out in 2020 and 2021. They were finally published. These were sister trials in the US cooperative group mechanism, looking at standard risk and high-risk patients and trying to find out an optimal induction maintenance strategies for these patients. Another very important study in this particular subgroup of patients is the Forte trial, where carfilzomib, which is a irreversible proteasome inhibitor, it was utilized as the proteasome inhibitor of choice in a 3-arm randomized phase 2 study. 2 of the arms contained KRD. One of the arms had carfilzomib with cyclophosphamide and dexamethasone as part of induction and post-transplant consolidation. And one of the arms was KRD without transplant for 12 months in that first randomization. And there was a second randomization of len versus proteasome inhibitor len as part of maintenance here again. So the arm that won out for PFS as well as depth of response was KRD transplant followed by KRD consolidation. And this was true for standard risk, high risk, as well as for double hit myeloma. So the myelomas that have 2 or more karyotypic, high-risk karyotypic abnormalities. So at MSK, based on the data that I've shared with you, this is our typical approach for standard risk patients. We are picking data VRD as our induction of choice. For high-risk patients, it's KRD based on the Forte data, but very soon we might be moving to either doing data VRD or data KRD for the standard or high-risk patients. And then post-transplantation, if the patient still has not achieved a CR, we might give 2 cycles of consolidation before moving on to maintenance treatment. But typically, that is not something that's required for vast majority of our patients. What about transplant ineligible patients? RVD light is a dose attenuated version of RVD that has been employed for older patients. This is a regimen that was developed by my colleague, Dr. Nupur Raj at Mass General Hospital, and Betsy O'Donnell published these data a few years back. But most myeloma centers do utilize some version of this RVD light for our older patients, especially for patients who may have high-risk disease. I think the most clinically relevant regimen in the United States for older patients, and this is something that we utilize quite a bit, especially with the subcutaneous formulation of daratumumab during the pandemic, is daratumumab combined with lenalidomide and dexamethasone. So the Maya trial looked at this 3-drug combination, comparing it to Lendex on its own. The one thing that I do want to highlight is the older patient population here. So the patient population was a median of 73 and 74 years, and more than 44% of the patients on this study were over the, equal to or over the age of 75. I do want to highlight another point in the study, that the high-risk patients made up a smaller proportion, about 14 to 15% of the study. Otherwise, the study results were quite remarkable. The original paper was published in 2019, and at the ASH of 2018, this was a late-breaking abstract presentation showing, phenomenal depth of response in this older patient population that translated into a median PFS benefit. So the median PFS is still not reached in the data Lendex arm, even after 5 years, almost 5 years of follow-up. And we actually updated these. We are updating these data at ASH, and that served as the senior author and investigator on this study. And by this, 56 odd month median follow-up, we were starting to see OS benefit in favor of the daratumumab containing arm of the study. So showing you that, if you have an effective regimen that gets patients into a good depth of response, especially in the standard risk setting, that can change the trajectory of the disease even in older patients. So this is an extremely important lesson to learn. We have to pick the right strategies for all newly diagnosed patients, regardless of age. And we are getting there in terms of delineating what would be the right strategies for different subsets of patients. So at MSK, our approach to transplant ineligible patients, we utilize both DARA-RVD Light as well as DRD. But again, this schema might change to quadruplets for all. We may not have to pick, whether we want to partner lenalidomide with a bortezomib-based regimen or daratumumab-based regimen. And it's likely that we might be, doing this for just a few cycles until patients get to a response plateau, and then change therapy over to either len maintenance only for standard risk patients or a PI len-based maintenance approach for high-risk patients. There are a lot of key questions that I do want to mention towards the end of my talk. This is something that we are thinking about. We are starting to use the C or the cure word in multiple myeloma because we are in possession of tools that can help us understand molecular and immunobiology of disease evolution and progression in myeloma. And we've started to do clinical trials where we are intervening early, in the precursor state. And we will start doing these studies in biologic, different biologic subgroups based off of immune status. We are starting to develop minimal residual disease testing tools in the peripheral blood, as well as with novel imaging. And then we're also now going from treatment forever to treatment for defined duration of defined durations based off of sustained MRD negativity. And then as patients get into this deep response, and we are developing these novel bispecifics and CAR T cell therapies with new targets like B cell maturation antigen or GPRC5D, all of those new targets will make this sequencing question very important. And if you all invite me next year, maybe I can update you on some of those advances in the newly diagnosed setting. In the end, I would like to thank the members of my myeloma service. I want to give them a shout out, as well as our transplant cellular therapy program. And I truly appreciate the kind invitation from the SKMT Symposium organizers. Thank you so much.
Thank you, Dr. Sadaswani. Definitely, we'll love to have you next year as well. It's always a great pleasure to listen to your remarkable talks. Last but not the least, Dr. Uzma Zaidi is our speaker. She's a consultant hematologist and head of BMT services in NIBD, National Institute of Blood Disorders, Karachi. She'll talk about updates in management of myelofibrosis and its the role of transplant in it.
Good morning, everyone. It is a pleasure for me to be part of this program, and I'm very thankful to the organizers of the symposium who invited me and provided me the opportunity to speak about primary myelofibrosis, which is a rare hematological malignancy. Before proceeding with the slides, I would like to declare that I have no financial disclosures and no conflict of interest for the material shared in this presentation. Just a brief outline of my presentation, starting with the diagnosis and risk stratification. I'm going to highlight the conventional treatment and the targeted therapies, and then I'll briefly discuss the role of stem cell transplant in the management of this disease. As we all know, primary myelofibrosis is a clonal myeloproliferative neoplasm. It's characterized by excessive bone marrow fibrosis and large spleen and large liver, anemia, cachexia, debilitating constitutional symptoms, and leukemic progression, which ultimately shortens the survival of the patients. In Western population, the estimated annual disease incidence rate is around 0.5 to 2 per 100,000 people. There have been a number of somatic mutations discovered who are supposed to play a role in the pathogenesis of this disease. And these somatic mutations can now be divided into two categories. JAK2 mutation, MPL, and KELA are considered to be the driver mutations, whereas there are a set of another mutations which we call as which are labeled as other mutations, and this category includes ASXL1, EZH2, KRAS, NRAS, IDH1, IDH2, U2AF1, and SRSF2 mutations. Driver mutations are supposed to be responsible for the disease phenotype, whereas the other mutations are considered to play a role in the leukemic progression of the disease. The current diagnosis of pyromyelofibrosis is based on the revised approach of criteria, which was published in 2016, and it involves a composite assessment of laboratory and clinical features. The main clinical feature on the basis of which myelofibrosis is distinguished from the other sister endocrine disorders is the megakaryocyte proliferation and atypia. And this revised publication has clearly discriminated between the prefibrotic and the overt phase of myelofibrosis. And the two features which distinguish between the prefibrotic and the overt phase of myelofibrosis are the absence of leukoerythroblastosis from the peripheral blood and a lesser degree of myelofibrosis, that is grade 0, or less than grade 1 reticuloendothelial fibrosis in prefibrotic phase of myelofibrosis. Another feature which is now included in the major criteria of the diagnosis is the presence of the driver mutations, that is JAK2, KELA, or MPL, and these are now included in the major criteria of diagnosis. The wide variability in the survival rates of myelofibrosis over the years has stimulated interest in identifying a number of risk factors which can predict survival in myelofibrosis patients. And in this context, a number of prognostic scoring systems have been developed or introduced during last 15 years. The first one among them was International Prognostic Scoring System, which was introduced in 2009, and it was designed to be used at the time of initial diagnosis. And it consisted of 5 variables. Number 1 was anemia, that is hemoglobin count less than 10, WBC count more than 25,000, presence of myeloblast in blood, age more than 65 years, and presence of constitutional symptoms. And based on these 5 variables, 4 risk categories were defined, that is low risk, intermediate 1, intermediate 2, and high risk categories. Later on, the International Working Group for Myelofibrosis modified this IPSS into Dynamic International Prognostic Scoring System, which can be utilized at any time during the disease course. The only difference between the two was that anemia, that is hemoglobin count less than 10, was assigned 2 scoring points based on the evidences available. Then after some years, 3 additional risk factors, including the adverse karyotype, low platelet count, and the need for red cell transfusions were incorporated into the DIPSS to develop a DIPSS plus scoring system. I would like to mention that adverse karyotypes are present in around 1/3 of the patients at the time of diagnosis in myelofibrosis, and it is also considered to be an indicator of poor survival. More recently, with more advancements in the understanding of the molecular pathogenesis of the myelofibrosis disorder, as we all know that the molecular mutations play a prognostic contribution in this disorder. Therefore, a new prognostic scoring system has been introduced, which is now currently being used, and it is termed as mutation enhanced prognostic scoring system. This mutation enhanced prognostic scoring system is basically designed for transplant age patients, that is patients who are 70 years or less than 70 years and who can undergo stem cell transplant, so that a better treatment option can be decided for them. This MIPSS system comprises of genetic variables as well as clinical variables. There are 5 genetic variables and 4 clinical variables included in this scoring system, and each variable has been assigned a specific score based on its prognostic significance. And 5 risk categories have been identified, that is very low risk, intermediate risk, high risk, and very high risk. So the new treatment algorithm in myelofibrosis is now based on this MIPSS version 2 for transplant age patients. And if you look at this treatment algorithm, patients who belong to very low risk or low risk categories, they have a median survival falling between 56 to 92%, which is very good. And if these patients are not too symptomatic, then they can be kept on observation only. There is no treatment required. On the other end of the spectrum, if you look at the high risk and the very high risk category of the patients, the median 10-year survival falls between less than 5% to 30% only, and therefore the preferred treatment option in this category remains allogeneic stem cell transplant. In our part of the world, most of the patients are diagnosed in intermediate to high risk, and for these patients, symptomatic treatment options are available, which we are going to talk about in the subsequent slides. The main clinical features of myelofibrosis due to which patients seek medical attention include hepatosplenomegaly, constitutional symptoms, and anemia. Anemia in this disease is attributable to the ineffective erythropoiesis, whereas the hepatosplenomegaly occurs because of extramedullary hematopoiesis, as the bone marrow is totally fibrosed. A number of therapeutic options have been used over the last 20 to 30 years with variable responses to address the different clinical needs of the patients in myelofibrosis. For anemia, corticosteroids and androgen therapies remain the treatment of choice and the most commonly used treatments that are available easily for controlling or improving anemia. Erythropoiesis-stimulating agents, though they are also frequently used for improving anemia, but they are not very useful or very effective in the treatment of myelofibrosis because of the extensive bone marrow fibrosis. And on the other hand, they are also associated with an exacerbation of splenomegaly. Therefore, they are not the preferred treatment options for anemia. Immunomodulatory agents like thalidomide, lenalidomide, and pomalidomide, they have proved to be beneficial in literature. But lenalidomide mainly works best only if there is a presence of deletion 5q karyotype of the patients. And as far as thalidomide and pomalidomide are concerned, they also work in a subset of JAK2 mutated patients who do not have massive splenomegaly or who do not have circulating blast, because the use of immunomodulatory agents is associated with cytopenias, that is myelosuppression. Therefore, in overt phase of myelofibrosis, these drugs cannot be easily offered to the patients. For symptomatic splenomegaly, hydroxyurea remains the first drug of choice for years and years, and it has shown to be effective, or it has shown to improve the spleen size in half of the patients. Around 40% of patients, hydroxyurea works very well, but the average spleen response to hydroxyurea in myelofibrosis is only 1 year. And after that, patients usually become intolerant or resistant to the use of hydroxyurea. The other two options for symptomatic splenomegaly include splenectomy and splenic irradiation. Both of these treatments have their own pros and cons. Splenectomy is offered to a subset of patients, and the major indications of splenectomy in myelofibrosis include increased red cell transfusion requirement, severe thrombocytopenia, symptomatic portal hypertension, or increased abdominal discomfort or splenic abdominal pain. But splenectomy is also associated with increased risk of infections, therefore should be considered only if the performance status and quality of life of the patient is good. As far as splenic irradiation is concerned, it may transiently reduce the spleen size and improve the quality of life of the patient. But again, its effect does not last longer, and the spleen again begin to increase in size after a few months. And radiation is also associated with severe cytopenias. Hence, I would say that apart from stem cell transplant, no other treatment can offer complete cure in myelofibrosis, and most of the treatments are symptomatic. Ruxolitinib, which is a JAK1 and JAK2 pathway inhibitor, it offers an effective alternative therapy for those patients who are intolerant or resistant to hydroxyurea therapy. Ruxolitinib was approved by the FDA in 2014 on the basis of two randomized multicenter phase 3 trials, the COMFORT-1 and COMFORT-2 trials. In COMFORT-1 trial, ruxolitinib was compared with a placebo drug, whereas in COMFORT-2 trial, ruxolitinib was compared with the best available therapy. And the primary endpoint of both of these trials were to achieve more than 35% reduction in spleen size after a period of 28 days and 6 months respectively. So the results of COMFORT trials showed drastic improvement in constitutional symptoms like abdominal discomfort, early satiety, night sweats, and inactivity. Patients who were treated with ruxolitinib had drastic improvement in the constitutional symptoms after the use of this drug. So long-term outcome of ruxolitinib therapy in patients with myelofibrosis, that is a 5-year final efficacy and safety data of COMFORT-1 trial showed prolonged survival of patients who were randomized to receive ruxolitinib. Here you can see that in the ruxolitinib arm, total 69 deaths occurred out of 155 patients, whereas in the placebo group, 82 deaths occurred out of 154 patients, and this survival advantage was statistically significant. Ruxolitinib has also been used in combination with other drugs, and there are a number of clinical trials that are still ongoing, in which ruxolitinib is combined with hypomethylating agents, that is azacitidine, BCL2 inhibitors, and PI3K inhibitors. But these trials are still ongoing, and the results are awaited. Apart from ruxolitinib, there are many other JAK inhibitors which are in different phases of development. And among these, fedratinib, pacritinib, and momelotinib are the 3 drugs which have gone through the phase 3 trials. Fedratinib, which is a highly selective potent inhibitor against wild-type or mutant JAK2, it received FDA approval in August 2019 on the basis of Jakarta-1 trial, and the results of these trials showed similar responses in terms of reduction of spleen size and improvement in constitutional symptoms, as shown in COMFORT-1 and COMFORT-2 trials for ruxolitinib. Recently, a multi-center series of 32 consecutive cases of blast phase MPN has been published, in which venetoclax has been combined with azacitidine or decitabine in use in patients who had accelerated phase of blast phase MPN. And according to the results of this study, complete remission was achieved in around 14 patients out of 32. And this complete remission was more likely to occur in the absence of the pre-leukemic polycythemia or post-polycythemia myelofibrosis phenotype, and in the absence of complex karyotype. Surprisingly, in this study, the authors published that the presence of TP53 mutation or the presence of IDH1 and IDH2 mutation did not affect the achievement of complete remission. Transplant in myelofibrosis. This slide basically shows the indications of hematopoietic stem cell transplant in the United States according to the CIBMTR data in 2013. And despite of the targeted therapies and new advancements in the management of myelofibrosis, you can see that MPDs and MBS still form a major part of allogeneic stem cell transplant in the United States. So the 2 major goals that we can achieve by doing a stem cell transplant in myelofibrosis is to cure the disease and to prevent its transformation into the acute leukemia. And the other major goal is to improve the quality of life of the patient by alleviating the constitutional symptoms. And these 2 goals can only be achieved with stem cell transplant. What is the best time to consult for stem cell transplant in myelofibrosis? As we all know very well that the 2 clear-cut indications of upfront stem cell transplant in myelofibrosis are the high-risk DIPSS and the intermediate to DIPSS risk. What about patients who are in intermediate 1 DIPSS score? These patients can also be considered for stem cell transplant if they have got additional disease characteristics, including the complex cytogenetics, if they are dependent on red cell transfusions, and they have a very low platelet count. Similarly, the presence of high-risk non-driver mutations, which I previously mentioned, including ASXL1, EZH2, IDH1, IDH2, SRSF2, TET2, or TP53, or a triple negative state, that is the absence of the driver mutations. These are also indications for considering patients for upfront stem cell transplant. For patients who were initially diagnosed with PV and AT and now they are in advanced phases of PV and AT, that is they've developed post-PV fibrosis or post-ET fibrosis, if they have an intermediate high-risk disease, or if they had a poor response to initial therapy, or their disease is progressed on treatment and they have high-risk cytogenetics, then they should also be considered upfront for stem cell transplant. This slide shows the relapse-free survival of HLA after HLA match-related and unrelated donor transplant based on the DIPSS plus scoring system. And you can see here that this black bar represents the low intermediate risk, and the best relapse-free survival is found in the low risk group as compared to the high risk group, where the relapse-free survival is less than 30% only. This table summarizes all those studies in which the role of ruxolitinib prior to stem cell transplant has been evaluated. In fact, the impact of a pre-transplant ruxolitinib therapy on the outcome of stem cell transplant has been evaluated. I'd like to highlight one study which was published in 2014, in which 22 patients received stem cell transplant, and all these patients were treated with ruxolitinib prior to transplant. And the results of the study showed that the overall survival at 1 year was much better in those patients who had a good response to ruxolitinib before transplant. I'll also summarize all these studies by mentioning the 2 important points that we should all keep in mind if we plan a patient for transplant. That is, if those patients who have been treated with ruxolitinib, if they're planned for stem cell transplant, then the drug should not be discontinued abruptly, because it may be associated with a rebound splenomegaly, or it may be associated with worsening of the constitutional symptoms. Therefore, the tapering of the drug should be done gradually over days or months, and free survival, and it was also associated with a high risk of non-relapse mortality. Another data which was published in 2019 included 56 patients who received stem cell transplant. In this study, only 10% of the patients received matched sibling donor transplant, whereas 87% transplants were heteroidentical, which were done with the children of the patients. And the outcomes showed overall survival of 56%, whereas the progression-free survival was 43 months only. And this study was associated with a high rate of acute GVHD, that is grade 2 to grade 4 GVHD was around 28%. So therefore, all this data shows that the best donor type for allogeneic stem cell transplant myelofibrosis remains the matched sibling donor type. As far as conditioning regimes are concerned, conditioning regimes of all intensities have been used in past in patients who have undergone stem cell transplant for myelofibrosis. Most of the authors, most of the study groups have preferred to use reduced intensity conditioning regimes because of the average older size of the patients and the presence of the comorbidities because of older age. If we consider myeloablative conditioning, the overall survival in these patients may be as high as 65%, but we should also bear the fact in mind that myeloablative conditioning is associated with an increased TRM, and it may be as high as 45% with myeloablative conditioning regimes. So it is suggested that MAC conditioning should be reserved for younger and fitter patients, whereas reduced intensity conditioning regime should be used for older patients, and it has shown a similar overall survival rate as compared to myeloablative conditioning regimes. The survival after bone marrow transplant can be predicted with the help of a comprehensive clinical and molecular transplant scoring system, which was introduced in 2019 by Gibbelman and his colleagues. And they basically evaluated 361 patients, and they identified certain risk factors in these patients. The multivariable analysis on survival identified 7 independent predictors of survival after transplant. And these risk factors included age more than 57 years, Karnofsky score of less than 90, platelet count of less than 150, leukocyte count of more than 25, HLA match versus unmutated donor transplants, the presence of ASXL mutation, and non-KRAS or MTL mutations. All these variables were incorporated into a 4-level MTSS score, and 4 risk categories were defined, which were the low, intermediate, high, and very high risk categories. And here in this figure, you can see the 5-year overall survival on the basis of this MTSS risk stratification. The highest survival, that was around 82%, was found in the low risk category, whereas the high risk, very high risk category of MTSS risk stratification had an overall survival of only 22%. So this MTSS risk scoring tool can be used practically if we are planning a patient for stem cell transplant. So I will conclude my presentation by saying that myelofibrosis is a complex disease with a wide spectrum of clinical presentation, and correct diagnosis and risk stratification according to a latest scoring system should be done in order to plan an appropriate treatment. There is no age restriction, but careful selection of patients for stem cell transplant, especially if they are more than 60 years of age, should be done. And reduced intensity conditioning transplants have shown better results as compared to MAC. Condition regime should be adjusted according to the patient's age, comorbidities, disease stage, mutation status, and of course, stem cell source. For GVHD prophylaxis, a combination of drugs, post-transplant cyclophosphamide and JAK inhibitors should be considered. With this, I end my presentation, and thank you very much for your attention.
Thank you, Dr. Uzma. We will start our Q&A session now. Do we have all our panelists online? Dr. Saad Usmani, Dr. Tanya, are they online? Okay. So our first question is from Dr. Tanya. This is a question from Dr. Azhar Shafi from Shifa International, Islamabad. His question is, what are your comments about phase 2 study in which FCR was combined with 2 years of ibrutinib?
That's a good question. It's an interesting combination where they did.
Dr. Tanya, we have some issues with the volume. We'll fix it.
You can't hear? You guys can't hear me?
Okay, yes, we can hear you now.
Sorry. So I hope you can hear me now.
Yes,
okay.
we can.
So IFCR phase 2 trial was done at Dana-Farber by one of my colleagues, Dr. Davids, and it's a way to give FCR the whole 6 cycles of FCR, but combined with ibrutinib for a fixed duration of time, typically 1 year. And what they're trying to do is to see if people can get into a more reliable, durable remission. And as far as I know, they actually did have a couple of patients who had myelodysplastic syndrome as a complication. And, you know, that's one of the main reasons why most of us have turned away even before the phase 3 trials showed that, you know, novel drugs were better than chemoimmunotherapy. A lot of us had turned away from FCR type drugs because it's just a little bit too toxic. Even if 1 or 2 patients get MDS AML, it's not worth it, given the options they have outside of FCR. There is another trial called IFCG that came out of MD Anderson that uses 3 cycles of FCG, meaning obinutuzumab instead of rituximab, but only 3 cycles combined with about a year of ibrutinib, and that had excellent results as well. And I don't know, I don't think they had MDS on that trial. I'll have to go back and check. So that may be an even better option with shorter FCG duration of therapy and a year or so of ibrutinib, and that could get people in a deep remission. So maybe that would be a good alternative. The problem is we haven't tested that combination or either of those combinations against, you know, just venetoclax, obinutuzumab, venetoclax, rituximab, or ibrutinib by itself, or ibrutinib, rituximab, or acalabrutinib. So we just don't know whether that chemo is necessary or not to get people in deep and durable remission. And if we could avoid chemo altogether, then we like to avoid chemo altogether in this particular disease.
Thank you. In fact, I will extend on that. When you mentioned in your talk that FCR and BR were used in the past, I think all of us felt a little sadness inside. Yeah. So when you mentioned, as with all the trials that you nicely explained, the availability of ibrutinib, rituximab, venetoclax, obinutuzumab, and acalabrutinib and obinutuzumab, considering, as you mentioned, that limited time or time-defined usage, plus the duration of maintenance, plus failure or relapse after using one treatment or the other. Considering the Pakistani situation, which one would you prefer as a first line? Is it venetoclax and obinutuzumab, or ibrutinib and rituximab or obinutuzumab?
I mean, it's an interesting question. I personally like the venetoclax plus obinutuzumab first because it's fixed duration. You can do it for 1 year and you're done. Obinutuzumab is for 6 months. Venetoclax is for 1 year, and then everyone can stop essentially. The only caveat is the deletion 17p or TP53 mutation patients who may relapse faster than everybody else. So you just have to be, you have to monitor. The watch and wait has to begin all over again. So I like the venetoclax plus obinutuzumab as long as patients can be watched in that early ramp up phase closely to monitor for tumor lysis and make sure they're hydrating well and things like that. But after the first few weeks of ramp up, then everybody's good to go. And sometimes I don't see patients for even 3 months at a time once they're done with their obinutuzumab. So I like that regimen better because it's fixed.
Okay, thank you very much. Another question is for Dr. Saad Usmani. One is a comment. A comment is from one of the doctors saying that we do not have availability of myeloma fish in Pakistan, so assessment of high-risk myeloma is probably not that accurate. And the question after that is how do you decide on maintenance of lenalidomide versus Velcade? Is Dr. Saad not online? Okay. Okay, so we'll just send him the questions. And are there any other questions?
Assalamu alaikum. So my question is for Dr. Uzma regarding myelofibrosis. We have seen a couple of patients in our setting where the patient's age is more than 65 or 60, and the patient is not transplant eligible because of many comorbids. And moreover, there is massive splenomegaly and cytopenias. And the platelet count is so low that we cannot give ruxolitinib or any hydroxyurea to relieve the constitutional symptoms and other symptoms of the patient. So what treatment options do we have in this setting where there is severe thrombocytopenia, there's marked splenomegaly, and the patient is not fit for surgery and for transplant?
Is Dr. Uzma with us?
Yes, I'm here. Can you hear me?
Yes, we can.
Okay, so just my video. Okay. So that's a very interesting question, and it is a very common scenario in Pakistan, especially because most of the patients are diagnosed in the advanced phases of myelofibrosis, like when they are already having splenomegaly and cytopenias at presentation, and in most of the patients at presentation they have cytopenias and large spleen, and obviously this is an old age disease, so we know that patients usually even if they're more than 50 years of age, they are not capable of tolerating the different treatment options that we have. So in our scenario, it is not very easy to treat these patients and offer, or to follow the international guidelines that I just presented. So we have to tailor the treatment according to the patient's needs and according to the compliance and the tolerance of the patients. So in what I do in such patients who are more than 60 years of age and they have a spleen size larger spleen size, along with moderate cytopenias. If they've got moderate cytopenias, then I try to keep them on the JAK2 inhibitor ruxolitinib so that they can at least maintain their quality of life and they are free from the constitutional symptoms. And at the same time, if you are not able to use hydroxyurea in these patients, that you have got an option of using interferon alpha 2. It is easily available in Pakistan. It is available in both forms, in pegylated form as well as the conventional interferon. So what you need to do is that it would be better that if the patient is in your close vicinity and you can monitor the patient frequently, the counts can be monitored frequently, then it is better to keep the patient on a fortnightly or a monthly dose of interferon along with the JAK2 inhibitor. That is a most suitable option that I've experienced in my patients. Side effects are very less, and it is easily tolerable, and it is cost effective also. So this is what I usually do in those patients in which we have no other options. And as I mentioned earlier, that splenectomy and spleen irradiation is not a very feasible option in our part of the world because of the side effects, and because of, even if you see, there are very limited centers that offer these treatments to these patients. Most of the radiation oncologists, they're also reluctant to offer splenic irradiation just because they know that it is a very transient treatment option. So it's better to keep them on a combination of interferon and ruxolitinib.
So even if the platelet count is less than 25, still you feel that we cannot give ruxolitinib in that setting.
If the
With
patient,
such low
most of the
platelet
patients,
count.
yeah, it depends if the patient. It depends if the patient is not bleeding, there's no clinical bleeding manifestations, and if you can keep an eye on the platelet count and the WBC count, you can tailor it accordingly. You may start with a very low dose, like 90 microgram once a week or fortnightly. It may work, and you can later on escalate the dose according to the platelet count or the response of the patient.
Okay. And can we give Revolade in these patients, considering that it also has a risk of bone marrow fibrosis, to improve the platelet counts?
No, I have never tried it, and I've never gone through any literature showing the use of any advantage of Revolade in myelofibrosis.
Okay, thank you.
There's
one question.
I think Kalan Rahil wants to add on to this.
Yeah, yes, sure.
Thank you very much. It's a very pertinent question. So what we do in our center for these patients, we put them on HMA venetoclax. So it is the low dose HMA regimen that is used internationally in these patients. That is 37.5 mg per meter square for 5 days and venetoclax for 7 days. We aim to debulk the disease. We aim to reduce spleen size in order to have a better symptom control. And then that does enable us, that has done in 2 to 3 patients in our then to restart ruxolitinib once the platelet count has improved.
Thank you, Dr. Rahil.
Dr. Rahil, I would like to just add one comment that venetoclax and azacitidine is, the trials have been done in mostly the accelerated phase or advanced phase when there are circulating blasts in the blood. Then it works better in those in this condition. So in patients who are still in the the early chronic phase, they have fibrosis, extensive fibrosis, but they don't have circulating blasts, and venetoclax and azacitidine might not be recommended.
So practically what we see that most of these patients are already DIPS plus high once they have massive splenomegaly with a high disease burden and they have significant cytopenias. So this regimen has helped us, and it is used internationally as well, to debulk the disease, and that enables in the future to deliver more targeted therapy.
Okay, thank you. I think I can summarize that if your patient is not as fit as you showed on the slide, who is running on the treadmill after Jakavi, then and has a high burden, disease burden, then you can probably use those combinations and take them there.
Exactly.
There's another question. Yeah.
My name is Dr. Ejaz. I would like to ask a question regarding the CLL. Sometimes we do have patients with thrombocytopenia in the range of 80 to 90,000, but they are stable and the patients do not have other signs and symptoms. So should we start on the basis of these stable thrombocytopenia, or we have an option to observe them?
I think you're asking because by IWCLL criteria, it says that if your platelets fall below 100, that's an indication for treatment in CLL. But you're right, I have many patients who stable in the 90s. I don't start if that's the only thing, and there's no other symptoms, no other signs, nothing else is going on, and the platelets aren't continuing to fall regularly. I just watch.
And madam, one more question regarding the supportive medicines.
Mhm.
Do you use the antifungal, antiviral in all patients or on a case-to-case basis during the
Case to
treatment?
case, if I'm doing combination venetoclax plus obinutuzumab or on the ibrutinib plus venetoclax trials and things like that, if there are more medications involved, then I'm more inclined to use PCP prophylaxis, PJP prophylaxis, and a cyclovir type HSV type of prophylaxis. I don't use antifungal routinely at all.
Thank you.
There's another
I
question.
would
for-
actually like to ask, if I may, I actually have no idea what is available in Pakistan in terms of CLL treatment, in terms of BTK inhibitors and venetoclax. Sounds like venetoclax is available because obviously it's being used in leukemia, et cetera, as well. But are BTK inhibitors available freely in Pakistan?
Well, yes, it depends on different hospitals in different cities. So generally, first line we use either FCR or BR if there's no 17p deletion, and then when they relapse, then definitely we do try to get our hands on ibrutinib. Depending on your institute, depending upon the restrictions, it might take a long time for you to get
Sure.
it. But if you're out in the private, then you can easily get it. And then venetoclax is readily available. Many centers are using it, and they might use it at a lower dose to begin with, as you mentioned, and then ramp it up. But it's patchy. That's why I said that when you said that FCR and BR is in the past, it feels a bit,
I
that
know.
you use
But
it as
you know,
first
it's
line
hard to
setting.
argue with the data. Now, these are American and global data, not Pakistani data, but still, you use data from, phase 3s showing overall survival advantage, and it's a little hard to
But maybe
argue.
next time when we talk to you, we might be doing the same thing.
I hope so.
So there's another question for Dr. Saad. He's not here, but we can answer based on his presentation. The question is, should depth of response dictate transplant after induction therapy in myeloma, or should we proceed with transplant with any response, whether it's CR or PR or VGPR? Dr. Saad Usmani said in his presentation that whether you transplant, it lies in the eye of the beholder, and that if you have the right strategy, particularly in a high-risk patient, if you have the myeloma fish, or whatever way you define with the limited resources, that it's a high-risk patient, and if you have DRA RVD, then obviously that is the way to go. Deeper response, get the deeper response, and get the patient to the auto transplant. That was I think that's what he suggested. Yeah.
So I have a, yep, sure. Do you want to take a seat? Let me just finish my question. You can go. So I have a question for Dr. Natasha. So that was a great talk, taking us back to our medical school, learning some, pathology behind it. So you mentioned, you shared your data on azacitidine plus venetoclax, the local AKU data. What are your comments about combining venetoclax with intensive upfront chemotherapy like DA or FLAG-IDA?
So for DA, we've not used it with D, but we've used it with like low dose anthracycline venetoclax. And again, like I said, the subset of patients who are 65 and above and are not suitable to receive the intensive chemotherapy, the compliance to treatment is very good. And the CR after a month of treatment with venetoclax and LDAC is almost 80%. The problem lies with the emergence of febrile neutropenia. It is very common in this subset of patients, and that's why what we do is, and of course the cytopenias, and what we do in these patients is that we don't give 400 milligrams of venetoclax because of the febrile neutropenia. They need to have very good prophylaxis regime when they finish the 7 days of LDAC. So what we do is that we put them on 100 milligrams of venetoclax and 100 milligrams of voriconazole. And that results in a very good pharmacokinetic dosing level equivalent to 400 milligrams of venetoclax as compared to 100 milligrams. So that's what we do when they're on triple prophylaxis regime. The febrile neutropenia becomes a problem. Otherwise, they tolerate this regime very well. And the durable responses can range from a year to 2 years in these patients. Venetoclax, the problem is that you continue it for at least 6 months and then wait and watch and see if they relapse or not. And after you stop venetoclax, after 6 months, the responses have been a couple of years for these patients.
Thank you. You can have a question.
So this is more of a comment on the CLL trial of Elevate-TN, where acalabrutinib was compared with chlorambucil and obinutuzumab. So I would like the panelists also to, comment on this, that since in Pakistan, the major cause of mortality in our patients are infections. And so I was just observing the data that the overall survival was almost similar, while there was a difference in progression-free survival. However, the infection risk was higher with the acalabrutinib as compared to chlorambucil. So maybe availability and cost is also an issue, but maybe for our patients, we can continue with chlorambucil and obinutuzumab, considering that there is.
So the only comment I'll make on that is that again, survival advantage, response rates, and all that we've seen. The chlorambucil plus obinutuzumab patients tend, as far as I know, that the follow-up of those patients for these types of AEs kind of stopped after they finished their combination therapy, whereas acalabrutinib is indefinitely continuing. So the patients are followed for infectious complications much longer. So I feel like maybe some of the AEs are missed in the chlorambucil obinutuzumab combination after their combination is finished, because it's fixed sort of duration therapy. But beyond that, yes, there are infections in the acala side of things as well, obviously. So one has to be careful, and that's why just the long duration of indefinite BTK inhibitor, even I don't like. I try to stop it, even with acala plus obinutuzumab. I try to stop it after 18 months or so, especially if patients are in a deep enough remission with the combination with obinutuzumab.
Thank you. Any other questions? Okay, with this, we will conclude our sessions. That was a very combination of exciting talks. Thank you, Dr. Tania, Dr. Saad Osmani, Dr. Uzma Zaidi, and Dr. Natasha Ali, who was physically here with us. Our next session will be in 10 minutes time. So
Thank you very much. This was
Dr.
quite an honor. I wish I can come in person again someday. I did an elective at Shaukat Khanum back in the day, and I really enjoyed
definitely,
it.
so. Inshallah, next time, consider you're already invited.
Oh, thank you so much. Appreciate it.
You're welcome as well, Dr. Tania, anytime.
Thank you. Appreciate it. अब अभी तो आजकल तो काफी हालात तो खराब हैं आपके शौकत खानम और लाहौर वगैरह में. It's always kind of dicey, but yeah, I've grown up in Karachi, so all that is natural to us.
Thank you very much. Thank you. See
Nice
you
to
then.
meet everyone. Khud Hafiz.
Allah Hafiz.